So I'll be speaking on HSV stromal keratitis and how to minimize the complications and recurrences in cases of HSV stromal keratitis. What makes HSV stromal keratitis such a challenging disease? So the multifaceted aspects of this disease, the diagnosis is very challenging in many of the cases. It is a great mimicker of different infections, and therefore the diagnosis always you're in doubt whether you are dealing with HSV or you're dealing with some other infection. You're often confused whether to give oral Acivir or topical Acivir in these cases, especially in the beginning, whether you should start on topical and then shift to oral, start on oral itself, or give both the therapies together. You're unsure how to taper the steroids. Most physicians, clinicians taper it in a regular manner from 10, 6, 8, 6, 5, 4, 3, 2, 1, like how you do weekly taper for anterior uveitis cases. And you're not sure how long to treat these patients, how long to keep them on Acivir, how long to keep the prophylaxis on, how long to keep the steroids on. And you're often dealt with blows of recurrences that the patient is doing well and suddenly comes with a significant recurrence of stromal keratitis or has an epithelial lesion or has a necrotizing stromal keratitis. And the whole cycle keeps repeating and repeating, and you're in a rut in terms of having unhappy patients because they are coming up with recurrences repeatedly to you. So immune stromal keratitis very basically typically presents with recent onset decrease of vision for the patient with mild pain and mild congestion. Usually the pain is not very significant in these patients because the epithelial defect is not there. There is stromal inflammation and infiltration that you can see. There will be cellularity that you will see. There will be mild edema, much lesser than what you see in endothelitis patients. So the edema will be there, but it's much lesser as compared to endothelitis patient. These patients also may have keratic precipitates, but usually they are not very large keratic precipitates in these patients. So to make diagnosis easier, one thing that you should do in stromal keratitis patients, because often these patients have had recurrences. So look for the clues that support your diagnosis. Ask for proper history of whether they have had recurrent episodes. Ask them whether they have had any redness, whether they have visited any doctor previously, whether they have had any treatment previously. Look for footprint scars. Footprint scars will tell you, they sometimes may be very faint scars. They'll tell you that this patient has had some episode of any form of keratitis previously, probably HSV. And look for any ghost vessels or vascularization that you can see within the stroma. The best way to look for vascularization in ghost vessels is in retroillumination on the slit lamp with a dilated pupil completely. That way you will not miss the ghost vessels. So let's look at a case, very typical case, 35-year-old female on with a BCV of 20 to 50, patient already on tablet Acivir prophylaxis BD and has presented with a recurrent episode where you see there is significant stromal infiltration. The patient has presented with decrease of vision at this point. So the question arises, for this patient, do I add topical Acivir or just step up the oral Acivir that the patient is already on? Second, what steroid frequency should I start on and how do I taper the steroids in this particular patient? And third, this recurrence has happened in the patient when the patient was already on Acivir prophylaxis. So what needs to be done about that? So let's look at each aspect one by one. So let's look at oral antivirals versus topical therapy. As Dr. Simi already said that oral versus topical therapy has equal results in terms of epithelial keratitis. But here in immune stromal keratitis, you have to understand you are giving topical or oral therapy at the time of acute disease only for prophylactic role to prevent epithelial lesion from happening. So it is not an active infection that you are dealing with. So the role here of topical versus oral is only as a prophylaxis to prevent epithelial lesion happening. And oral Acivir is equally efficacious as topical for epithelial keratitis. So here also you can either step up the oral Acivir or you can keep the oral Acivir BD and add topical Acivir over it. This has to be continued at 5 times per day dose, whether oral or topical, till the steroids use is more than 4 times per day. So this has to be understood that the dose has to be 5 times per day till the steroids are more than 4 times per day. Now, you prefer oral Acivir where there is associated ocular surface issue in the patient, where you expect that there is some neurotrophic component. If it's a graft, then definitely oral Acivir would be preferable. So in wherever you feel there is a dry eye component, Patient has severe MGD associated, so you prefer oral Acivir. Also, in many of my patients, I prefer stepping up the oral Acivir from BD to 5 times dosage rather than adding a gel or an ointment. The reason being that the patient is already on that treatment, it's easy to explain to the patient to just step it up for some time. Acivir is a very safe drug overall. Long-term studies have shown that. Second, the ointment causes some blurring, additional blurring to the patient, and they are not very comfortable putting the ointment in some patients. Those patients, the gel formulation of ganciclovir has better tolerance. So when you look at the HEADS trial, two things are important. That faster resolution was noted with topical steroids, but the time of initiation of therapy did not affect the final outcome. So even if you started the topical steroids later on, then also the final outcome was similar. And there was recurrence of disease in 50% of the patients within 6 weeks of stopping the steroids. So that what it means is that the steroid therapy for 10 weeks is insufficient for stromal keratitis patients, and it needs to be tapered more slowly, and the lower the dosing becomes, the longer can be the tapering period. So you can't keep it on 10 times per day for 5 weeks. So you have to reduce initially and then make the tapering period longer when the dosage becomes lower. So what regimen usually we follow or I follow is that I start with prednisolone acetate 8 to 10 times per day and taper weekly till the dosing reaches 4 times per day. At this point, I am either using oral or topical Acivir 5 times per day till the patient has reached 4 times per day dosing, and then slow down the tapering further. What do I mean by that? That when I make it 3 times per day, the dosage period will become 2 weeks. When I make it 2 times per day, the dosage period will become 3 weeks. When I make it 1 time per day, the dosage period will become 4 weeks. And even after that, if this patient has had previous recurrences, I would shift to alternate day or twice or once a week dose for a much longer period, maybe another 1 month or 2 months, till I know that entire inflammation period has gone down. And during this period, I will keep the patient on oral Acivir 400 mg BD. So how to deal with recurrences now? How long to continue on maintenance for these patients, and the disease is still recurring with Acivir, so what to do in those cases? So you have to understand the efficacy of antivirals in preventing recurrent episodes is only 41% reduction in recurrences and 50% reduction in stromal keratitis cases. The more the number of previous episodes that the patient has had, the more the risk of recurrences, and shorter is the period between the different episodes. So if the patient has already had multiple episodes, this patient is likely to recur more and more. So the benefit of using oral antivirals, also prophylaxis, also lasts only till the patient is on the prophylaxis. So you can't expect that you give for 6 months and hope that the effect will last another 6 months. That will not happen. And also, acyclovir and famciclovir are equally efficacious. So if you want to keep a lesser frequency dosing, you can shift to valacyclovir OD dosage. So repeated recurrences on prophylaxis you are having, what you might be doing wrong in that patient. First thing to look at is, are you tapering the steroids too fast? That means you have to maintain this patient on lower dosage of steroids for a longer period to keep the inflammation in check. This is the most common cause of the patient having recurrences, that you are tapering the steroids too fast. Second, if the patient is having recurrences repeatedly with this dosage of Acivir, do you need to increase the dosage? So there are studies which have shown that at least 800 mg is needed per day for reducing the recurrences, and recurrence rates are higher at lower dosage than that. And there are also studies which have shown that slightly higher than 800 mg does reduce the recurrence rates, but they are not randomized trials, so we don't know the complete efficacy of that. But yes, you can shift the patient to higher dosage 400 mg 3 times per day, or you can increase the dosage to 800 mg BD also. Again, you have to keep the renal function test in check, but overall very safe. And if the patient is having repeated recurrences, there's no harm in increasing the dosage. Or are you dealing with a resistant strain? Now this is a tricky one, and usually we don't, most people will not have the facility to know whether you are dealing with a resistant strain. You can consider alternatives, but I will say that this is a very rare scenario in our clinical setup. So 3 mistakes to avoid while dealing with stromal keratitis. Do not rush to start topical steroids. If you are doubtful about your diagnosis, there's no harm in delaying for a few days and then starting the steroids. Just see the response on your antibiotics. If you're unsure about whether it's infective, send a corneal scraping if you feel there is an infiltration capable of giving you some material. Do not taper the steroids too fast. This is the biggest mistake that most ophthalmologists make while treating HSV. And do not stop oral Asever prophylaxis too soon. To conclude, knowing the interplay of steroids and antivirals is the key in treating stromal keratitis. Slow tapering of steroids and higher maintenance dose of Asever if the patient is having repeated recurrences. And most importantly, explain to the patient what this disease is, and they have to live with it. It is not going to get completely cured. They will only stick with you as a practitioner, as an ophthalmologist, as a cornea person, if they understand that what they are dealing with is going to keep recurring, even if you are doing your best. But you are going to take them through this journey, holding their hands and taking care of every recurrence and preventing those recurrences. And you understand every time that the recurrence happens, what you are doing wrong, you have to tackle it. Okay, so talking to the patient is very, very important in Asever. I talk to HSV patients maximally after refractive patients. So it takes almost 20-25 minutes to every fresh HSV patient to explain to them in detail that what we are dealing with, what they can expect, because often they will come to you that I am taking Asever, why am I coming up with recurrence again? So you have to initially itself tell them that it will only reduce your recurrences. It cannot completely stop those recurrences. So you cannot expect the patient to not have any recurrence even if they are using Asever prophylaxis. Thank you.